You want me to start, Shazia, or are you going to give some housekeeping?
Yes. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Ahlan wa sahlan to all participants and our speaker. I'm Dr. Shazia Iqbal. I'm chairperson and head of continued professional development activities at Saudi Society for Medical Education. In medical education, talking about a patient safety is very important to train our undergrad medical students. And in Saudi Med itself, this is one of theme in which Saudi Med, they have enforced that students should graduate as a competent in such an effective way that they don't compromise on patient safety. We learn by medical errors and how we can overcome these errors, how we can reduce communication gaps so that our patients are in safe hands. So this is a very hot and current issue, and I'm very much delighted that today's topic for presentation for this webinar is about patient safety, especially in undergrad medical curriculum. And I'm very much delighted to introduce to our eminent speaker, Prof. Valerie West. Prof. Valerie West, very warm welcome to Sesame Riyadh office. A brief introduction about Prof. Val West is that she is FRCGP, she is FRCP, she is a master's in health professional education and PhD. She is Professor of Medical Education in Primary Care at School of Medicine, Aberdeen University. She is Emeritus Professor of Medical Education, Faculty of Medicine and Health at Calais University. She is Honorary Trier Executive Board Member at Vonica. She is Program Lead for Masters in Medical Education for Healthcare Professionals at IHED Ireland and University of Warwick, UK. So she has a lot of work and publication in this medical education area, especially patient safety. Now over to you, Prof. Valerie, so that we can start with our webinar.
Thank you so much. Thank you, Shazia. Shukran.
Welcome.
Salam alaikum. Let me just share my screen.
Salam.
So has that worked? Good.
Yes.
So thank you so much, Prof. El Mahdi, for the invitation, and inshallah, I'll meet your needs. You've asked me about teaching in patient safety, but I've changed the title slightly to integrating the teaching and learning of patient safety into the undergraduate curriculum. Because I think, as you say, you've got a very good curriculum of content, but as I understand it, one of the challenges is how you're going to deliver that across UAE and across your things. And I think you're right, Prof. El Mahdi, and Shazia in asking the questions, because just to start with Albert Einstein, this wise quote, which I use a lot in assessment too: everything that can be counted doesn't necessarily count, and everything that counts cannot necessarily be counted. Because that, I think, is one of our challenges with patient safety. What we're asking is, are our students, are your grads, when they graduate, safe to practice? And we haven't really yet got our heads down exactly how we establish that, how we set a standard for safe practice when they leave us from medical school. And I want to talk about that from 2 points of view: obviously the patient's point of view, but perhaps even more the graduate, our students' point of view, how we should be looking after them and nurturing them to go into what's a difficult environment. So I'd like to start by, Prof. El Mahdi, by asking you if we could work just to look at what are some of the challenges are and why you asked for this webinar. Then to explore the competencies that we need to deliver safe patient care. And then to look at some of the ways we're changing how we think about medical education to establish lifelong safe practice, because we don't just want them to be good when they leave medical school. It's a lifelong skills we're trying to develop for them. And then reflect a bit on the assessment. But I think I've decided, putting this course together, that probably that is such a big issue, it should be really addressed separately in another webinar. So if I may now look at this first challenge and ask you, Prof. El-Mahdi, if you could just say 3 or 4 minutes on why you asked for this webinar. And please, all participants, I need this to be interactive. I hate looking at a blank screen. I can't see you. Shazia is going to keep an eye on the chat for me, but please, as we go, and now, if you could put what questions you want to ask of this webinar in, it would really, really help me know how to direct it. And Prof. El-Mahdi, would you like to come in at this stage for just a couple of minutes?
Yes, thank you very much for responding, and thank you very much again for giving me the chance to speak first about the challenges. Actually, as you know, in 2009, the WHO published a guide for medical schools, followed by a guide for multi-professional education guide. And I was at the time working at Al-Imam University, and I was asked by the Vice Dean for Academic Affairs to translate the guide into a course to be taught in the university. We started by spreading the culture first. We didn't want to impose a course, so we asked for a meeting, and in that meeting we tried hard to convince our colleagues that there is a need for such integration of such a course. And actually, we were faced with tremendous resistance and difficulty. And we had to introduce the course as not as a mandatory course, but as an elective course. And we continued teaching it as an elective course. And during the teaching of the course, the students were not the problem at all. They actually loved it because we used to take them to hospitals to see the issues we were talking about, and we used to take them to CIBAHI, which is responsible for accreditation of hospitals, to see how they deal with that. But the issue of the first challenge was to convince faculty that there is need for such a course.
And what was the resistance when it's so fundamental to the work of a graduate that they're safe to practice?
Yes, the resistance was not about integrating components. They said we are already dealing with that. So we told them we don't see it in the curriculum. It is not explicit. So we need to see it in the curriculum as an explicit components and explicit modes of delivery that are suitable for such an issue dealing with patient safety, especially the foundational part. I mean, speaking about the system, the quality in the hospital, all of these issues. But the applications, they said we are already dealing with infection control, we are already dealing with medication safety, we are already dealing with invasive procedures. So the three major issues related to patient safety or applications of patient safety, there was no issue with that. They said we are already dealing with that. But the foundational components, we had some resistance introducing them. And then the second issue was who owns that? This was another issue. The ownership of the course or those components. So even the elective course was actually handled by the public health or community medicine department. They say, yes, we are the people who teach leadership, management, quality, the environment, communication skills, and those issues. We already teach those, so they actually were on board dealing with these issues in the course, which was an elective course. So these are the two major issues we faced: the ownership of the content and convincing faculty.
Okay, that's really helpful. So it's making it explicit and integrating it across the course, but also ownership as well.
Yeah.
So that's truly helpful. Shazia, I've just realized my watch isn't working, so I might occasionally ask you to give me the time so I know how I'm getting on
I will
time. Good.
I will be.
Good. I see somebody else in the chat has just said that the challenges are the same. I think initiating the culture within the curriculum, and I think I
Exactly.
agree with that, Malak, that it is a lot about culture, and the students. It's getting the students to really. You've got to inculcate it with them about safe practice, and that's going to be a lot of what I'm arguing. I hope it'll be helpful, Prof. El-Mahdi, in moving you forward.
Yeah.
So let me. So this is one of the challenges, isn't it? I worked with Cyril Chandler in my early days, and this is a famous quote, which you may well have heard, that whereas medicine, when I trained back in 1966, was simple, effective, and it was relatively safe. Now it's complex, it's effective, and it's potentially dangerous. So this is a real challenge for us as we move forward to educate our graduates nowadays. And I think probably those of us who've been around for quite a time will really share how difficult our job is as medical educators. And it was great privilege to visit you. When was it? About 3 or 4 years ago, to look at this medical school where, Shazia, you're based, to how it developed. But we do live in a world where the change is exponential, and we really don't know what jobs these students are going to have in the future. And I will argue that against, we've got artificial intelligence coming in, and I will also argue about how much population needs are changing. There was nothing like the internet when I learned medicine. It's just phenomenal, and the sort of tools that our students will have in the future will be so different from even the mobile phones we have nowadays. And we can speculate what the problems in the future are, but I would never have perceived 50 years ago when I was a medical student, if you had a heart attack, the ward was full of men who were put to bed rest for a whole month with a bedpan. They weren't allowed to get out of bed. And now you can be back at work within a week or two, having had your stents put in. Huge change. And so this is our responsibility. We're preparing students for a lot of uncertainty, a lot of change, and a lot of challenge. And I quite agree, Malak, I think it was, that we've got to inculcate in them the skills for facing this uncertainty and risk, much more than was conceived when certainly I started out in medical education. And this is interesting too, as well. Prof. El-Mahdi, in your talk, which I very much enjoyed looking at, you bring into is human. This was back in 1711 when Alexander Pope first brought this to life. And now, gosh, 3 centuries later, we're still having, this was from the USA in 2000, another report onto is human, with this staggering figure that in the USA, 98,000 people were dying every year. So I've spent some time looking at statistics, and in Europe and in the UK, 8 to 12% of all the hospital admissions at any one time will have medical errors occurring. I looked across Saudi Arabia and what I could find of your incidents of medical error, and they're equally high, if not a bit higher in some of the papers I saw. So there's no doubt you've got a problem. And if people challenge you, Prof. El-Mahdi, and say it's there, well, say the errors are there and we've got to do something about them. And we're not doing enough now. I think you've got the statistics for that. There's absolutely no doubt of that when you look across the literature. So here we are with this error. And also, I've said that's to protect the patient, but I think we also must protect our students as future graduates and yourselves in active clinical practice, because the problem isn't the bad people, and that's not why the errors are occurring. It's often the systems, and they need to be made safer in the hospital. So I say this because inevitably all of us, and I can't see your faces on the screen, otherwise I'd ask you to put your hands up, but I expect most of us in active medical practice have made mistakes. And I think it would just not realistic to think that we're creating graduates who will never make mistakes. So it's therefore really important that we help them understand what to do when they do make mistakes. Because we certainly know in our country, when we go up to the regulator. Fortunately, I never had to, but it's very, very stressful and can even lead to suicide because it can really get people down so much. I don't know what it's like in Saudi Arabia if you get a problem, but I'm looking you a bit at Shazia. Is that a problem too if you have ERA? But it's something to think about. So like if anybody want to say anything about that?
Anyone want to say anything, any experience when you find such kind of litigations and know any story anyone want to share? I think problem is the same everywhere. So yes, definitely.
Yeah, I'll move on.
It is stressful.
Can I share my personal experience?
Yes, please.
When I was
Yes,
a medical
please.
student,
Yes,
when I was a
Dr.
medical
Shahid.
student, when I got a medical student in year 3, don't ask me when, a newly recruited registrar, she couldn't find the proper syringe to give insulin, 4 units. So she picked up a syringe, wrong syringe, filled a 4 cc, 4 milliliter of insulin, pushed it in one go, and then after never saw the registrar again in the ward because of the guilt that she had. Obviously, we can understand what went to the patient, but then after that, registrar perhaps quit the profession altogether. So she, I'm not safe enough to practice if I cannot see the difference between an insulin syringe and a regular syringe which you use for injecting anything. So you see that one mistake, I always felt like that one mistake that she did, she stopped her career.
And how did you feel watching that mistake? Did you feel you should report it, or how did you feel?
At the time it was reported, and different people were being called that what went wrong, why those syringes were mixed up with the insulin syringes are pretty tiny syringes, and those regular the big ones, how come they were mixed together? So you see, she just randomly picked it up from the box, and then without realizing that from the vial of the insulin, she just had this 4 milliliter of insulin.
Well, that's a perfect example, isn't it, of the system letting somebody down, but then the awful consequences for them. So thank you so much for bringing that up. That's really illustrated my point so well. Thank you. Shukran.
Thank you.
So this is looking at some of the challenges that are coming to our students. I've used this slide for several years now, but I just wanted to make the point today already that patient safety is getting even more complicated with comorbidity. We teach everything, we tend to teach it as disease-based, and we have guidelines based on diseases, but it's getting so much complicated when you have patients with a lot of diseases getting increasingly old. How will artificial intelligence impact on our work as doctors? Some people say we won't need doctors. I think we will, but our role as medics clinicians will be much more not on the basics, but on handling uncertainty and risk and working out what the computers can't work out. So it'll be the really tricky sides of medicine, which must be exposed to error. And of course, we fill our students full of technology, but they're not a knowledge through technology, but they're a generation who are going to have the technology at their fingertips. So they will need different skills in how to address problems when they arise. It's all changing so much that we need to think about it. And new diseases. Who would have thought of coronavirus coming when I first made this slide, probably back in 2019. But here we are in the middle of an epidemic. And what has that taught us? That's taught us really a thing, and I think it should be explicit in any curriculum, about well-being. And we know how COVID, I'm sure in your country too, has impacted hugely on clinician well-being. And we also know that if you're not on top of your job, then you're more likely to make an error. So I think attending to well-being has been one of the most important lessons we're learning for undergraduate education as we hopefully begin to emerge from this awful pandemic. So I think that as well is, that's why I'm talking about, it's not just about protecting the patient. We've got to protect our students with the skills to really work in what's going to become an increasingly complex environment. And there's a lot of in the literature and in your literature too in Saudi Arabia about medical error. So I just put, those of you who are interested, just put this paper in. You're welcome to have the slides afterwards, Shazia, if people would like access to them. But this is a paper which is pointing out how we've got to look after our clinicians to protect patients, and how we've got to develop those skills. So, as you said, and as you outlined so well in your lecture I watched, Prof. El-Mahdi, you've got the content, haven't you? This is a wonderful content. I enjoyed going through it. For those of you who haven't got it, it really goes through all what we need to get into the content. But what it doesn't really go into is how you make it explicit in a curriculum and integrate it. And somehow that's what we need to think about today, is how you can make it quite clear to students what they need to learn and staff how to do it. And I think probably be more caring of our students in what are becoming very difficult systems. I think we've become very patient-centered, certainly in Europe, but I argue increasingly we don't look after the students enough. It's a tough environment for them. And I put this in, this is from Kuwait, when I was examining there once, when we'd had a fierce argument about whether somebody should pass. They'd failed 4 times. And the argument was they'd done the course. It was a postgraduate course. They should pass because they'd done the course, but they weren't passing the assessments at the end. And I saw this stop at the red signal, life is precious. There has to be a clear parameter when a doctor isn't safe. There really has to be that, and I'm sure you have to deal with that in your medical schools too, but it's very difficult to actually set the standard for what is a safe, competent practice for patient safety. So I've come in this about perhaps from backwards, but I think we all have to accept that assessment does drive learning. It wags the tail of the dog, as we say in the UK. So one of the questions I'd like you to be thinking about and to leave this webinar with are, how do you know your students are safe to practice when they graduate? I think it's a complicated area and I can't cover it fully in this webinar, but how do you, when you set their final exams, decide they're actually safe to practice? I'm sure your people who argue against you, Prof. El-Mahdi, will say we just know, but do they just know, and how much do you, and how much do you just tend to have a bias towards students you think you like and don't? I think it's really hard to have a firm line about what's competent. And I expect you'll have an even bigger argument for that, Prof. El-Mahdi, because that's setting your final exams is really hard. So I wanted to start by thinking about what level of patient safety will your students be when they leave you. Some of you may know of the Dreyfus model of skill acquisition, which goes through the various stages of becoming an expert. And when students leave us from medical school, we know they're not experts. We go on to postgraduate training. Do we ever stop learning? Probably not, but we do become much more automatic in how we work and function. So we're looking in this model across both the range of capability, and I think probably medical students would be competent, and please comment if you're not, but I don't think we expect them to learn as to be proficient or expert. And the other thing to think about here is, and I've met very different systems, and certainly recently supervised a master's thesis of somebody working in the Lebanon, where the students weren't expected to be really very competent when they left, because they went straight into really heavily supervised clinical practice, where some students, for example, in the UK, go off into foundation training, but they could still be in the hospital at night, expected to run everything. So there's some supervision, and we say they're fit for, they're not fit. They're pre-registered, but only registered after a year, but they're not always supervised. And so when you think up here, there needs to be a sense of responsibility from actively making decisions. But we do recognize that that sense of responsibility for patient safety will increase with more experience. So I'm hoping I'm making that clear, that these are clear decisions we need to make when we're thinking about what is the level we want to inculcate in our patients. So I put this in because it's one thing as educators you can think about doing within your schools, and perhaps bringing the people who are resistant in so they can begin to see what the problem is. But it's trying to define what your competent graduate will be for it to be a safe graduate when they leave you. And this was done in a European medical school with a group of people on a Teaching the Teacher course, when they had to sit and think about what competencies the students needed when they leave them. And of course, the first one is they've got to be safe there to work in supervised clinical practice. They would always have a senior there, but it had to be safe at that level. And they decided they should be patient-centered, understand the population and communicate well. But these were the other things that I think come into that curriculum. They should make safe, timely and ethical decisions and work in teams. And working in teams is key in your curriculum too. And they should be self-directed lifelong learners, able to praise and to know their own limitations. I'm not sure that comes out very strongly in the curriculum. It's so important that you know when you don't know. So I think if whatever level, even year one, encouraging your students to be quite honest when they don't know, rather than pretending they do know, is probably a skill you could even start with straight from the beginning as you're thinking about teaching them. So I would suggest that that might be something that you might think about doing. Does that make sense? Does anybody want to comment on that? Would it be challenging to do in your environment?
Anyone want to comment? Please unmute and can share. There is one comment on your talk that, you know, when you don't know is an excellent phrase. That's great. Yes, please, you can continue, ma'am.
So then we go back to defining where they are when they leave you. And I would think competent would be about right. Can you nod, Prof. El-Mahdi, if you think that's about right?
Yes, indeed. I will keep my comments for
To the end.
later. Yes, yes.
So I won't pick on you then. So if you go back to the curriculum, it's great. It covers everything. And I really think it brings out most of these things. I don't think it quite brings out well-being and how important it is that students learn what to do, not to burn out, and recognize that if they are tired and stressed, then they can make mistakes. And so it's really important to look after your well-being. And quite a few courses now bring in mindfulness and yoga practice and those sort of things into their undergraduate curriculum. So this is the key question or structure that I put in, suspecting that perhaps you had this issue of how you make it explicit in a curriculum. And I agree, Prof. El-Mahdi, you do have to make it explicit. And this is the one way that most of us are working to make it explicit. And that's by thinking about how our curriculum is done. And we are all moving, and I know many medical schools still use the Flexner model of 2 years basic science learning and then 3 of clinical learning. But many of us are moving away from that now, so you have a more integrated approach where you have some contact with patients earlier on in the curriculum, and then you keep some of the science going to the end. But the most important thing about this model is that from the beginning, students are working with patients and you're getting them used to how to handle patients. So I also wanted to bring in this idea of the spiral curriculum, because I think that's an excellent way of building spirally these patient safety competencies for a student. You start from year one, and I'll show you how, but then you build it up each year. It's a good thing that it was Ron Harden of AMY introduced this back in 1999. But the idea is that you take your students up the curriculum, but each year you bring back the knowledge of the year before and make it a bit more complicated. So you're increasing the complexity of what they're learning, and you're increasing their expertise up to the competent level if you're thinking of that Dreyfus model that I've just given you. So you don't simply repeat everything, but you're working out how you can build patient safety all the way up. So you could start in the year one with trying to help them to think, I'll talk about later some of the things, but about being really clear about being honest and integrity and their basic standards of professionalism. And I think we did discuss professionalism when I was with you. But this is the way that we're making things like patient safety explicit, by having a vertical theme that goes through the curriculum from year one to year 5. So you actually map out explicitly, and I think it usually needs a champion. So when you say your problem is who is responsible, you make a champion, but not necessarily put it in public health or anywhere. You just get even a clinician or somebody really senior to say, you're really going to champion this. You're going to develop it with a small team and work out how it works. We've done that in curriculum for professionalism and ethics. You have a team of people led by somebody who's passionate, and I think we've already discussed you could be passionate, who build it up. So this would be when I worked in Manchester, we had a theme for professionalism called Doctors in Society, and we brought in ethics, leadership, reflection, and teamwork, and built it as a theme with somebody leading it. So I was looking at patient safety. So again, I haven't done this in the order you could do it, but you could gradually bring in being aware of one's limitations, perhaps at the beginning, and understanding about being an effective team player, and then raising it up. So once they're in clinical, they can think about raising concerns, like the concern about that poor registrar who gave the wrong insulin dose. Students need to understand what to do if that happens to them. And we certainly did a lot about raising concerns when I was Dean at Keele, because our year 4 students were in one of the trusts. You may have heard it, the Francis report. There was a big concern about patient care, and we actually had medical students in that hospital. The care was at night really with nursing, but it was so awful that some of the patients, if they wanted some water, had to drink it out of the vases, the flower vases. It was just awful, awful care. And there was a lot of concern that we still had students in that hospital. They hadn't witnessed the care, but we did a lot of work with them about what to do if they did witness poor care, about whistleblowing. So these are all things that you would explicitly build up. And I bet, Prof. Almadi, if you started to show your people who don't think they already teach it, so that they would understand there were gaps, or at least get them to make it more explicit when they're teaching these things to students, as it's part of the vertical theme. So this is how it would fit in to coming back to it. You think across your 5 years or 6 years, whatever your curriculum is, and you can have other themes like professionalism or communication going up the middle. But I know all your medical schools, for those of you listening, will probably have very different curriculum. But it's certainly a way in the curricula I've been working with, that we've been working to make things like patient safety explicit and make it clear that we build the right competencies. Is there anything in the chat, Shazia, or should we just go march on? Any thoughts?
You can continue. So far, there is nothing in chat.
Okay, and no questions there. So, and what time is it, Shazia? How long do I have?
8:35. We have half an hour more.
Okay, good. So we're getting on fine. So understanding the theoretical frameworks. And I wanted to bring in some ways of teaching that I think are really important as we move forward. Let me just do it this way. So I'm sure many of you do this already, reflective practice. This is something to start from right at the beginning of medical school, because this is the way that you will build their skills for handling error when it happens. And we all know about significant event analysis. So at Keele, when I was dean, we pushed reflective practice, and the students really didn't get it at the beginning. But then when they actually graduated, they came back to us and said, I'm so pleased you made us do this, because it works so well with what we're doing now. I think you probably know this, Shazia, don't you? Can you just nod if Kolb is key to everybody in medical education? It's having a concrete experience. So if, like, you do something wrong, say you do give a wrong injection, well, that's quite a dramatic one. But if something happens and you see you haven't done it very well, then you need to actually go away and let me just get this right, think about what you've done, often with somebody else. So it's, I don't know whether you have mentors in your students have mentors, but have somebody they can talk to about it. And then when they talk about it, this is what's difficult, is to get them to actually think about what went wrong and what they had to go away and learn, or what they had to go away and do so it didn't happen again. And then they can go with them, they can set their goals to go away and work out what they're going to do differently next time. And a lot of schools now are trying to build that into portfolios that the students keep reflecting on these when they happen. And we're having to do it more and more in most postgraduate medicine for appraisal and revalidation, that you keep an annual portfolio and have an annual appraisal which is based on reflective practice. So that is one thing that students don't necessarily like. My experience with our current Masters of Medical Education, it's a difficult thing to do for Middle Eastern countries. So perhaps it's something to try and inculcate more with students to help them think about what they're doing. And we're changing learning much more. If you're interested, Mike Mesereau has described something called transformational learning. And that's where the students, you give them something that makes them a bit uncomfortable. You might send them off to see a patient, or we're doing some online learning now where they've really got to play games and look at difficult things. And it's only when they've been out of their comfort zone that you get them to reflect about what's happening and help them, and then help them go forward. That, I think, is a perfect way for patient safety. If you look at the curriculum, the WHO curriculum, it talks about changing your cases that you use, or your problem-based cases, and adding in something difficult at the end, and then making the students think about how they might do it differently. So that's a way you can adapt current material to make it more challenging for students, but also making them do things like a difficult simulation and then reflect back on it. But it's that reflection back that's really forward. So we're talking much more about trying to learn, not from lectures, from knowledge that the students have anyway at their fingertips, but giving them skills to learn when they're out of their comfort zone and have maybe with patient safety issues. I won't go into this now, I just put it in because it does break it down round, so you can see self-examination. Then they've got to plan their action. It's really a cold cycle, but it's a different way of thinking about how to deliver teaching, which I think we've got to do, prepare them for the future and uncertainty and risk. We all love to make everything black and white, but all of us in clinical practice know that medicine's grey. There's often not a right answer, and we've got to get our students used to thinking about that if they're going to practice safely in the future. So this is really coming back to an area that I really can't, I felt you'd probably have had enough by now, because we know that you can't concentrate very long on Zoom. It's even less than in real life. But it's back to how we know our graduates are safe when they leave us. And it's really difficult. And I've for years been working in on assessment in universities where they just set a 50% pass rate for their graduates without thinking what it means about competent being safe to practice. I worked this medical school where this definition came from. The finals pass mark was 42%. Now, how many patients would be happy with a doctor who passed an exam with 42% when they were going out to do their finals? Many universities, it's 50%. And it's very hard. If you think it's hard to change them to think about patient safety, Prof. El-Mahdi, it's even harder to get them to change and find set a standard for a pass mark. But it is a whole different area that I don't think we can go into today. But you do have to be able to set a standard of minimal competence for when a student is just about safe. You can do it using this definition. You work out just what is acceptable, and there are various techniques for doing that. But we have to move universities from setting a pass rate of 40 to 50%. We can discuss that, I hope, whether that's what you're doing in your practice now. But this is one thing you could do when I was thinking through the practicalities for you, and which we do in the UK. And you might like to think about doing it in your institutions to see how well they feel prepared for practice, or even perhaps to persuade your antagonists that they don't feel well prepared for practice. Because I would be pretty sure you would find that they didn't feel as well prepared for working in the context of work. We did some work with the GMC, General Medical Council, research we did looking at whether the students were prescribing safely. And we found when they went into foundation, there were 10% of errors in prescribing. And in fact, when we really looked at it, doing more qualitative research, we found it wasn't that they didn't know how to prescribe. It wasn't they didn't know how to write a drug chart. But when they had to do it in the context of being on a busy ward, being asked to do a lot of things at the same time, that's when they found it really difficult to do. And that's why the mistakes were happening. So is your curriculum preparing them enough for the stress of the medical environment and being able to do things in those contexts? So I put one reference here you might like to look at, but you could do surveys with your graduates when they've been on the wards for about 6 months or a year, and just ask them, did we prepare you well for practice? And see what they say. And if not, what could we have given you more help with? Not really. Is that challenging? We can discuss that. But it was one way I was thinking how you can move forward if you haven't actually got it on the ground yet, and how you could get data to show that you could do things better. So I'm going to wind up now and open up for questions, and certainly look to hear your ideas. So we've moved, in fact, from the curriculum to thinking about how you might assess them as they leave. Just to summarize, we started really with saying, you know, whoever's leaving our medical schools now, they're going to make mistakes. We've all made mistakes. I've made mistakes most often because I haven't communicated well with a patient. That's why skills like that are really important. But we all make mistakes. So how do we learn to deal with them? And then we were thinking about what level they're at and arguing what competency is, how you can make it explicit. I hope those ideas might have helped. And the basic way we need to think to safely practice, and I think the reflective learning, difficult it is to get into people's head. I remember a student say, this is psychobabble and it's a waste of time. I think it's absolutely key to how we practice in the future. It will help with exams if we can bring this into your thing, but also it will help with the students and their well-being as well. So I will thank you then for listening. Inshallah, this will help you move forward. But Prof. El-Mahdi, back to Einstein, don't stop riding that bicycle. Keep your balance and you keep it moving. So that should mean good luck. But when I'm on Google trying to translate, I find it difficult. Does that mean good luck, Shazia? I hope so in
yes,
Arabic.
I think so.
You need to ask me because she's not
Arabic, purely Arabic
speaking. I couldn't find. I kept getting different things.
Yes.
Anyway,
Yes,
I'll finish there. I'll stop sharing, and then hopefully I can see people. And we can have a
yes.
chat.
Thank you very much, Prof. That's a wonderful talk and very much enlightening in a way that it really gave us a it's thought-provoking in a way that now medical educators should think it seriously, that how important it is to train and should be part of formal medical education in undergrad curricula. Because once we are stuck in some medical error, it's like it's a matter of your career then. Yes, Dr. Ali Rahili, you raised your hand.
Good evening, Prof. Wes. Thank you, Shadia, Prof. Mun'im, for this really very interesting talk. I learned so many things. I was wondering, since you guys started the lectures with some of the obstacles or the resistance, just my questions to the Prof. Wes, does technology is playing part with these obstacles and resistance, because now we depend a lot on the artificial intelligence to prevent lots of error, and we can see it in a daily practice. You know, a dose of medications, it will be stopped by the machine, and so do you think that maybe the enthusiasm of teaching an undergrad of this patient safety will be not, the stakeholders will not be enthusiastic about putting lots of effort to be done in the curriculum, and because of the artificial intelligence and technology? And thank you very much. And Had Saeed. So Had Saeed is a good one.
A wonderful question, Ali. If you don't mind me calling you Ali. And you can think about that at so many levels. I don't think even when you have technology at your fingertips, it's necessarily good. I remember even if you've got your prescribing at your fingertips, you can miss the drug if you're working under a lot of pressure. So I think even though you've got the technology, I think what we showed with prescribing was that you can misuse that technology when you're under pressure. I remember mixing up dipyridamol. I can't remember what I mixed it up with, but it's very easy. So I don't think the technology will increasingly, what you'll need is the skills to stay calm in a complex environment and not make mistakes when you're using technology. Does that make sense?
It does.
I think another strand is artificial intelligence. Who knows what that's going to mean for future doctors? Many have argued we won't need doctors. My argument is, yes, we will need doctors, but they will need skills to deal with the things that artificial intelligence can't deal with, i.e. when it doesn't fit into a patient pattern, so it gives the wrong answer, or if you've got to look at the risk and the uncertainty. And that's why I personally am convinced that our students must be trained not to think black and white, because technology can think black and white, but they've got to be able to think grey around the complexity of patient care. So I hope that makes sense too. I think, though, COVID has really shown us how we can use technology to help with those skills. We've been using, I didn't develop it, one of the doctors up in Aberdeen developed a game we call Champion GP, which uses gaming, and we get the students to compete, and all sorts of things come into them as though they're in a GP surgery and they've got to do this and that and this and that. And that they have to compete and they draw cards and they don't know what's coming. And they really like it. And they say it's like transformational learning. One student said, "You take me out of my comfort zone." And I like that because then I remember it so much better. So my other answer, Ali, you put me really on the spot with such a wonderful question, is that you can use technology to help people with uncertainty as well. So it has an advantage in helping us train. I think COVID's opened a lot of opportunities for us. That's hardly an answer, but I hope it helps a bit. Go away and think about it, Ali. I think there are many levels to that.
Thanks.
Who's next, Shazia?
Thank you very much. Thank you very much. Yes, Dr. Al-Sayed.
Good evening, everybody. And thank you very much for arranging this webinar and for the nice thoughts Dr. Valwars has reported for us. Actually, we are in Gulf Medical University in UAE. We have adopted certain policies for the patient safety. For example, before the students go to the clinical stage, we have the hospital orientation before. And then during the rounds, we have what we call sign in and sign out, just to direct the students in sign in for quarter of an hour, what they are going to do the day. And then after sign in at the end, sign out at the end of the day, we are discussing with them what they have seen and their reflection about the cases. We are asking them also to write down during every rotation something called the ethical event report, so that they see some ethical event or some mistakes, and then they comment on it. They discuss it with each other, they discuss it with the faculty, and then go to the references and see what references are saying if this mistake is happening. This is during the rotation. Before they sit for the exit exam, we have developed what we call readiness to practice test. They have to pass this test before they sit for the exit exam. And this test is based on the entrustable professional activity of that. And during this, we subject the students to a critical situation with patient coming with the casualty or so. And we see how he is behaving with the patient. Is he safe? Is he know his limitation? Or he rush to do something which is not in his capacity? And during this exam, he can call the consultant and ask him something even. And then we evaluate him. And he is not allowed to the exit exam except if he passes this exam. Of course, he can apply for this exam once, twice, even 3 times he can pass. And then until he passes and he reach the safe level we need.
That's
this is just command. Yeah.
That's perfect. That's just what I'm talking about. So that's just perfect how you build reflective practice. And then but I presume what stage are they at? Are they year 4 and 5 or?
Year 5.
5.
Do you find they do that in the second half of year 5?
Do you find they're very well prepared for reflective practice, or do you have to teach them how to do it?
We have
when they reach you.
We are teaching during the rotation.
Yes. Are they good? You have to teach them. So this is a way you could build it up over year 1, 2, 3, 4, 5. So that the time they reach you, they're very good at reflecting and build on it. The other thing that would be really interesting is then to ask them when they graduate how much what you did helped them prepare them for practice. Because
we do that.
Yeah. Oh, wonderful. And do they like it?
Yeah.
Yeah. Good.
Yes, of course. Yes, of course. Yeah.
So perhaps that's something you could sort of have a discussion around the region about it, see if other schools are doing it. Sounds perfect. Well done. Give you a clap.
Thank you very much.
So,
thank you very much, Prof. Al-Sayed, for sharing your experience. Yes, Dr. Al-Mardi.
Well, I have many issues to address, but anyhow, I think Dr. Mona has put her question in the chat.
Yes. Yes.
Would you like
Prof. Mona? Yes, Prof. Mona, she has asked one question, that how can we evaluate the impact of patient safety curriculum?
I think that's a really good question. And of course, what we really want to know, if you're thinking of Kilpatrick's evaluation, is not just do they feel safe, but are they safe? So it's a really good question. Do you have any ideas how you might do it? Or is that unfair to ask Mona about that?
We would like to hear from you.
Mona?
Would you like to, can you speak, Mona? Or would you rather not?
Mona is not around now, but you can, if you can answer.
I think it's, I think you've got to look at if you look at how I think you've really got to work out what they learn or what changes their behavior when you're teaching them. And that's a challenge we all have, as we tend to set our evaluation at did you like the course, rather than has it, I don't know whether people know Kirkpatrick's model of evaluation, but most of us, satisfaction isn't what we want to know. We want to know what they learned and how it changed their behavior. So I think a lot of it is about getting them to reflect after they've had some teaching as to what they will now do differently, a bit like Prof. Sayed was saying, how they go away and get them to write down what they've learnt and how can you evaluate if they're safe to practice? It's really hard to do when they're actually in the clinical environment because they all go off into different places. And I don't quite know how you do it in your clinical environment. But
Yes,
I'm looking for ideas about how you do that. Prof. Al-Mahdi, have you got any ideas? You've got your hand up.
Yeah, no, my hand up is, I wanted to ask about a few things, but I would like to first comment. First, I would like to congratulate Dr. Sayyid Zayat from the Gulf Medical University. But I know they are lucky because the chancellor is Professor Hussam Hamdi. Am I right? So,
You are
have
right,
a
yes,
leader,
you are
you have
right,
a
yes.
leader, a famous medical educator. You are lucky. You are not like us. But anyhow, this is a congratulations for you. Dr. Ari Raheli asked about artificial intelligence, and I would like to just remind him of the issue of the use of technology. If you know about Boeing, the largest aeroplane by Boeing, and actually there are 4 or 5 incidences it crashed because it is completely automated using artificial intelligence. So now people are holding back on this issue of artificial intelligence as far as human life is concerned. So don't worry, this artificial intelligence will not take over. It is already introduced into the medical practice, but not to the degree that you say you don't need to teach about patient safety anymore. Now I come to my question. Actually, Prof was, in my talk in the conference, I mentioned a concept introduced by Dr. Drur in his paper in 2011, and he also wrote it again in the book by Professor Hardin and John Dent. It's about learning by experiencing error. And he said we need to change our cases so that our students actually experience the error and then reflect on them and so on. Any comments on that?
Yeah, thank you so much. That's exactly why I introduced transformational learning and Mezero, and it's worth going away to look at that as a way forward. That's what it is. You take them out of their comfort zone.
Yes.
And then they, as the student says with the gamification work we're doing, they're uncomfortable, they have to work. Often you try and do it in a safe environment. So it would be in a small group when they feel safe with each other. And then you get them to really think about it afterwards. That's a perfect way of doing it. And then, but in a safe environment, because you've got to feed back very carefully if you've really made them feel uncomfortable. So how you give the feedback is absolutely key as well.
Yeah.
Not just that was a dreadful error, but getting them to talk about it, how it made them feel, and then work out what they felt they did well and then what they could have done better. But that is transformational learning, and that's what Dr. El Zayat is using as well, I think, as well. Sending them off to do something and then getting them to debrief. But there's no doubt if we do something out of our comfort zone and then have to put it right, we remember it much better.
Yeah.
We learn much more deeply. It kind of goes into the things to embed better in our brain, uncomfortable as it is.
Yeah. The second issue, it's not how to teach, how to integrate it into, I told Sayyid Zayat that you are lucky, you have a leader who is a medical educator, he's interested in innovation and everything. But the less lucky institutions, how how would they go about, challenging the resistance and smoothing it? How to introduce the issue of integrating the curriculum into your curriculum, the patient safety curriculum into your medical curriculum. How to go about, you said you need the champion group. Would that do the trick in our part of the world? I would like to hear from others and from you, Rufwas. Yeah.
I'd love to hear from others because everybody has such different curricula.
Yes.
I mean, it's evolution or revolution, isn't it? And I suspect for most it's evolution. So I expect one way of doing it is to present the fact that your students don't feel prepared for practice. I'm sure they do, Dr. El-Zayat or Prof. El-Zayat in your university, but I would bet quite a few students don't. And so you can show them that. So produce some evidence if you can. But I think in most of the curricula, it's there. You might need to put other bits in, but I would probably go for evolution. So try and build it in and show it's there. But I want other ideas, really, from other people. Dr. El-Zayat.
Well, if may I allow me to share our experience at our college. Well, patient safety is one of concern in our curriculum. When we map curriculum, it is being taught longitudinally throughout the courses, especially by manipulating in problem-based learning scenarios, giving some kind of challenging situation in which patient safety is concerned. However, we are not having sole course, or you can say that focused few weeks course, which is specially dedicated for patient safety. And we are thinking that, yes, that should be part of it, and maybe in the form of elective course, so that once students pass out, they are they know different issues and basic principles of patient safety's management. So this is how we are doing at our institution. Like, we are just addressing patient safety in longitudinally within PBL scenarios, but there is no sole course for it. So again, this is my comment, as well as I need recommendation that is it must to have a course itself with patient safety, or is it enough if we are thinking that our learning objectives or program learning outcomes are being achieved within different bits within different courses?
I don't think it's a course, because you're developing lifelong learning skills. And that most of patient safety is not about learning about error, but it's learning how to cope with error. So you're trying to build the strategies for students to be safe, because they're going to err. You're not going to stop error, but what you've got to do is exactly what Dr. El-Zayat is doing, is to help them learn what to do when they've made an error. But it would be good to have other views. I may be wrong, but I think the challenge is you've got a curriculum, but it's not just a course, as that WHO document suggests, which is why you're probably having difficulty in getting it as a course. I think the thing is you need to build it all the way up. From starting at the beginning to getting them to understand reflection, and always saying, if you don't know the answer, then you don't know it, go and look it up.
I can see one comment in chat box by Dr. Asma. She shared her experience that in our college we use both methods, course as well as integrated in other courses. So it depends upon different curriculum.
Would they like to come in and comment? The person who made that comment, so we can ask them more.
Dr. Asma, if you would like to share by unmuting your mic, and you can share your experience if you want. Meanwhile, any other questions?
Hello.
Please.
Hello, everyone.
Hi.
I am Dr. Asma. Hello, everyone. Hi, doctor. Thanks for your nice presentation. Hello, Dr. Shazia. I'm the doctor. I am director of medical education unit in Ibn Sina National College. We use in Ibn Sina, we have a follow course for patient safety. It is introduced actually in level 7 4th year, and this course before the start of the clinical rotations, and to give the students يعني we actually use the patient safety curriculum of WHO. We use the same topics of this guide. It is very nice, the guide, as Dr. Abdelmenem provided in the CIMIC conference. We use it always, and also in BBL modules. يعني we have modules in the second, third years. Like you said, Dr. Shazia, we يعني put the students in situations concerning the patient safety issues. So I am agree to use both methods for يعني reinforcing the information for the students.
That's really helpful. Do you use simulations as well for them to learn how to make errors in safe environments? Do other people use
Yes,
simulations?
Doctor.
Yeah.
Yes.
Any other who want
If
to
I may ask Asma,
Yes,
who
yes,
is the owner, Asma, who is the owner of the course? Who is coordinating the two courses, the solo one and the integrated components?
The solo one, it is prepared. Actually, we use it in IBE, interprofessional education. It is shared between medicine, dentistry, pharmacy, and the nursing students.
Excellent.
And it is planned by medicine staff under supervision of medical education unit.
Good. So I think, thank you very much, Asma. Thank you for coming in and sharing. I think Marwa wants to come in.
Yes, Marwa.
yes, Assalamu alaikum. I'm here in Taiba University of Medina. We have a patient safety course as a part of the patient-centered care curriculum introduced in the 4th year for medical students. We allow them to go through all the issues related to healthcare quality and patient safety applications through providing them with cases, simulations, rules to know about the regulations, everything that they need to know about, even the ethical issues related to these. And I gave them some we say, I don't want to refer it as an assignment, but they would go and practice while they are in the hospital. They would look for the hospital accreditation body. They would look for the patient safety rules applied, and they would come and tell me what they have found so that they learn to observe. So as long as they graduate, they would know how it is practiced and what they, sometimes they criticize what they see in communication and such things, so they go for better behavior afterwards. And it's also assessed in the OSCE stations in their exam.
Good. How do you assess it in the OSCE stations?
We have a communication station, how to break bad news to the patient and how to break medical error. We also have one about the medication errors and prescribing skills. This is how we are presented as a course in the OSCE exam, yeah.
So it's explicit in the assessment. Do people have standard setting for their finals exams, or are you stuck with a university percentage?
Percentage, mostly universities, they have percentages, not to standard setting at undergrad levels. But so far I can see that almost all questions have been answered, and we are approaching to our time as well.
May I just share with you one experience when I taught it as an elective. I taught parts of it as an elective, and I was talking about errors and the difference between errors and violations and infringement and whatever. And then I told them to err is human, and you need to report that, and you will not be punished. And then they told me, don't tell us, tell them. So they wanted to make sure that the hospital environments understand this issue of to err is human, and if we report, we are not going to be punished. They wanted some effort to be exerted to actually prepare the hospital environments. And now there is, of course, the Saudi Center for Health Safety and Sibahi. They are all working towards preparing leaderships in the hospitals to accept error as an inevitability, but avoidable harm. So
yes.
They are concerned, the students themselves.
Yes, I think the challenge coming out of all this discussion is there are ways of doing it which you can share across the region, but perhaps there needs to be some thought, and thank you for your input about whether they actually, how do you know if somebody isn't safe to practice when they leave your university? Because I'm not sure 50% pass marks do that. I think you have to think about what is the minimally competent skills that when they leave us, they need to have to be safe to practice, which is a huge cultural change and quite difficult.
Yes, Dr. Shahid.
Thank you very much, Dr. Shazia. First of all, let me congratulate you on regularly arranging this seminar, and they're very thought-provoking.
Welcome.
And inviting a variety of people having different experiences. And on the same note, Professor, thank you very much for telling us more about patient safety. You know, what is now happening in the world? Certain parts of the world are getting more litigative societies. They are scared of telling people that I'm so sorry, I made a mistake, I made an error, and I shouldn't have done it, and I did it, and I'm sorry about that, and I will not do it next time. Would it be consequence free? Answer is what? We don't know. Should I tell you what mistake I made? It depends on you, not on me. Okay. How am I being taught before? You know, a few days ago in a laboratory, one of the students, she broke a glass slide under the microscope. Because she was trying to focus it and she just broke it. I said, all right, not a problem, but be careful in when you pick up these glasses, and would you mind to report to the manager of the laboratory that you broke a glass slide? And she was scared to death. Then how can I tell the director of the manager of the lab that I broke a glass? I said, well, it's human error that you didn't realize how high the stage was going on a microscope. You broke it, simple as that. But you need to tell that, all right, now we are one glass slide short from the box. He knows we might replace it, but you see that now. What is the day that we should start teaching these young souls that, all right, if you make an error, tell your immediate supervisor. They will help you. They will help you how to, how to report it and how to have the experience, how to reflect and not to do it again. And if it happens again, what you need to learn and all kinds of these things. It's an endless, and it's not that simple.
That's perfect way to end, isn't it? Because it really, it's such a good point that this is what we need to help people learn from day one when they come to medical school, to create a safe environment and help them. Most of medical error happens through communication, so getting them to learn to communicate, but also to make them feel safe and help them with the skills to learn to confess if they've made a mistake and have the courage to go to somebody who's a bit fierce. I think a lot of medical education for centuries has been a bit by learning by terror and bullying, and we need to change that now and make it a safe environment and help people learn that it is okay to make a mistake. People will make a mistake, and that you need to then say you've made it, and it won't be as bad as they think. So I fully agree, but I think we start from day one at medical school to help people do that, and we don't bully and terrorize them.
Correct. Thank you, ma'am.
I know. Thank you very much, Dr. Shahid and Prof. Well, for your comments. Before we end session, allow me to take one question. Yes, Dr. Shaima, please, quick question, because we are running short of time now.
Actually, I wanted to share my experience. I participated in implementing teaching assistant patient safety curriculum for medical students. We started from the year one in the course of early experience course. The students reflect on their experience in their portfolios. They are assessed by modified essay questions and OSCE. We have simulated patients to teach and to assess them. And we also let them to reflect on their experiences.
Good.
Thank you.
Thank you very much.
Thank you so
Thank
much. Thank you very much. So I hope we have taken up all questions, and I would end this session now by saying very thank to Prof. Valdes for this enlightening and very much elegant talk, and we covered almost all concerned points very nicely. And I will share recording of this session with all participants. And thank you so much to all participants, and thank you very much, Prof. again.
And if you allow me, I would like to personally thank Professor Valerie Was for a wonderful session. And it was really different because we couldn't push interactions in the past, but now it was very interactive. Thank you very much.
Well, I wish you good luck, and inshallah you'll get it explicit. I wish you all well, and thank you very much for being here and listening.
Wish you well. Have a good day. Thank you, Prof. Bye-bye.
And inshallah we'll meet again. Bye.
Yeah. Bye.
Thank you. Thank you, Prof. Thank you.
Pleasure.